Alright, let's discuss on ischemic changes in ECG. Alright, progression of ST elevation in MI. First, within minutes, we can see hyperacute T, which is a tall peak T. It can be more than R. And then after 1 hour, we can see ST elevation. After 2 hours, then only we can see Q wave. After 1 day, then only we can see T inversion. And then the ST elevation and also T will be resolved, remaining Q wave. This one we can look at the V1 and V2. Because normally V1, V2 tak ada Q wave. But in STEMI, patient who had STEMI, before there's a pathological Q wave in V1 and V2. The hyperacute T wave in MI is quite broad and also blunted. Okay, it's different than the hyperkalemia punya peak T wave, di mana dia punya T wave punya endpoint is sharp. It's called Eiffel Tower sign, or it's called tented T wave lah. The for MI is not tented. Lepas tu, the deepening of the Q wave, it is pathological if the depth is 25% more than the length of the QRS. Okay, more than a quarter lah. And the width is less than 1 box. And there will be no Q wave in non-STEMI. ST elevation will resolve usually within 2 weeks. If it's still persistent more than 2 weeks, we suspect ventricular aneurysm. We can use ECG to confirm MI because it has high specificity. However, ECG does not rule out MI because it has low sensitivity. So if there's no sign of MI on ECG, we cannot say that the patient don't have MI. However, if there's sign of MI on ECG, the patient is confirmed to have MI. For diagnosis of ACS, first we look at the clinical sign like chest pain or bone history. Second, do ECG. We can see STEMI. Once we see STEMI, straight away send to cath lab immediately. No need cardiac enzyme test because it will be a waste of time. If no STEMI, we do cardiac enzyme. If positive cardiac enzyme, it is non-STEMI. If negative cardiac enzyme, it's just unstable angina. For management of STEMI according to CPG, we do continuous ECG. Second, give sublingual GTN, tablet aspirin, clopidogrel, analgesic and oxygen. If it is less than 3 hours, straight away to PCI. More than 3 hours, the PCI is no more beneficial unless it is a persistent angina. Otherwise, more than 3 hours, we give thrombolytic, streptokinase, and plus minus if it is persistent angina, we give IV PCI. For STEMI, we not only look at one lead, however, it must be positive STEMI at 2 contiguous leads. And also, the ST elevation equals to 1 box. ST elevation equals to or more than 1 box only is enough. As in all leads except for V2, V3. V2, V3, it must be 1.5 boxes and above for female, 2 boxes and above for old male, 2.5 boxes and above for young male who are less than 40 years old. Whereas in the posterior ECG, only require half box only to be positive STEMI, at only 1 lead is enough, whether it is V7 or V8 or V9. Contiguous leads are the group of leads that represent an area of MI. 1 AVL, V5, V6 for lateral MI, V1 to V4 for anterior, V2, 3 AVF for inferior, V7, 8, 9 for posterior, and if there's STEMI at the AVR, already is a very serious problem. There's a triple vascular disease. For any suspect of inferior MI, must do right-sided ECG and also posterior ECG. Okay, because especially for inferior, mesti dia akan kena right-sided 40%. Manakala posterior pula about 20%. This is how normal 12-lead ECG looks like. This is how right-sided ECG looks like. We must put the V3, put V3R, V4R, V5R and V6R, because we suspect in this patient the V1 there's ST elevation in the septal area, so we suspect the right side pun kena MI juga, and it is clear here that the right sided pun kena MI juga, because we can see here V3R to V6R has ST elevation. This is an example of posterior ECG, whereby in this patient there's ST depression in the V1, V2, V3. This is a sign of MI. So this patient, we do the posterior and change the V4 to V7, V5 to V8, V6 to V9. Okay, 7, 8, 9 here, which we can see there's ST elevation in the posterior leads, indicating there's a posterior MI as well. Now, let's talk about reciprocal changes. Okay, what does it mean by reciprocal changes? Is actually ST depression seen in the opposite lead from the ST segment elevation. Like as we can see here, reciprocal changes in the 2 and 3. See, 2 ada ST depression, 3 ada ST depression. So these are called reciprocal changes, and this is reciprocal to the opposite lead, which are these are the inferior leads. The opposite lead would be their STEMI at the anterolateral V1 to V4, 1 AVF, 1 AVL, V5, V6. However, we can see STEMI at V1, 2, 3, 4, AVL and lead 1. Okay, reciprocal changes is highly sensitive as an indicator of acute MI, and it is frequently seen in larger infarctions. Okay, these are the reciprocal changes. If it is MI STEMI involving the septal anterior, it will or extensive anterior lah. There will be reciprocal changes in the inferior leads, and suspected artery will be left coronary artery. Okay, Whereas if it only affected the V1, V2 or V3, V4 or higher lateral, anterolateral, and the anterolateral without involving all of the precordial leads, V1 until V6, only parts of the precordial leads, okay, and plus reciprocal changes at the inferior. So the suspected artery is LAD or left circumflex, left anterior descending or left circumflex. If the affected area is inferior STEMI, reciprocal at the lead 1 AVL, the suspected artery will be right coronary artery or circumflex, left circumflex. If it is at lateral and involving reciprocal changes at the inferior leads, the suspected artery will be circumflex. If it involves posterior MI, the reciprocal at the anterior leads we will suspect the posterior descending artery. Okay, PDA. If it involves the right ventricular, involving the STEMI of the lead 2, 3, AVF, V1, V4R, and reciprocal changes at 1 AVL, we suspect right coronary artery. MI also can lead to bundle branch block and also fascicle block. There's 4 types of blocks: the right bundle branch block, left bundle branch block, the anterior fascicular block, and posterior fascicular block. From here we can see the if RBBB, the V1, V2 will be like M shape. Okay, if LBBB, V5, V6 yang macam M shape, macam ada sikit M shape dekat atas QRS complex dia. Small m LBBB, big M RBBB. Okay, for anterior fascicular and posterior fascicular, it looks like this. For anterior fascicular block ada left axis deviation, whereas the posterior fascicular block ada right axis deviation.